The most useful question after a melanoma diagnosis is not simply what procedure comes next. It is which pathology finding changes the plan. Welcome to this Contrast Explainer on melanoma treatment options. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Getting a diagnosis like this can feel incredibly overwhelming, right? But modern medicine has developed a highly logical, evidence-based sequence to determine exactly what you need. By understanding the specific details of your biopsy, we can completely replace that initial anxiety with clarity. Okay, let's dive into this calm decision pathway. We'll be walking through the pathology ruler, the surgical margin branch, the sentinel node fork, stage-matched therapy, and we'll wrap up with the exact questions you should be asking your doctor. Let's get started. Section 1, the pathology ruler. Think of your initial pathology report as the starting measurement that dictates the entirety of your tailored treatment pathway. Literally every single decision going forward is anchored right here. When those biopsy results come back, they answer some absolutely fundamental questions. We need to know, is it melanoma in situ, meaning it's limited to the epidermis, or is it actually invasive? We're also looking at Breslow thickness, whether there's true ulceration, and if there are any additional staging features. It's incredibly important to realize that the right treatment is built from this specific pathology and your overall stage, not just from hearing the terrifying word melanoma. So the crucial point is Breslow thickness. This isn't just a random number. It's the microscopic measurement of exactly how deep the melanoma has invaded your skin. Alongside ulceration, this specific measurement is the primary driver for everything that follows, from how wide your surgical margins need to be to whether we check your lymph nodes, and even whether drug treatments are on the table. Section 2, the surgical margin branch. Once we have those measurements, we transition calmly to surgery, which is the usual primary treatment for localized cutaneous melanoma. This perfectly illustrates how your Breslow depth directly maps out the exact excision margin the surgeon will measure on your skin. It's pretty straightforward. If the melanoma is in situ, the usual clinical margin is 0.5 centimeter to 1 centimeter. If the depth is 1 millimeter or thinner, it's a 1 centimeter margin. Over 1 to 2 millimeters deep, the margin increases to 1 to 2 centimeters, and for anything over 2 millimeters, a 2 centimeter margin is standard. The pathology report literally draws the map for the surgeon. Now, you might be wondering, shouldn't they just take as much as possible to be super safe? Well, actually, no. Wider is not always better. A randomized trial following patients for nearly 20 years showed that for thicker melanomas, a 2 centimeter margin and a 4 centimeter margin produced similar survival rates. So relying on the standard 2 centimeter margin for these cases achieves the medical goal while safely avoiding a much heavier reconstructive burden for you. Which brings us to a really common assumption. Does every melanoma need Mohs surgery? Because Mohs is so well known for treating other skin cancers, people often just assume it's the default here too. And this brilliantly illustrates why surgical choices come down to precision versus scope. Wide local excision remains the standard for most invasive melanomas. Mohs, or staged excision, is highly selective. It's particularly useful for lentigo maligna, poorly defined in situ disease, or minimally invasive tumors located on anatomically constrained sites, like your face or neck, where saving every single millimeter of healthy tissue is absolutely critical. But here is a strict rule. Even when selective, margin-controlled surgeries are used, the central tumor must always go to permanent pathology. Why? Well, occasionally, a lesion thought to be in situ actually proves to be invasive. Sending that center tissue for permanent pathology ensures we don't accidentally lose vital Breslow depth and node data before closing up the surgical site. Section 3, the sentinel node fork. Moving to the next branch in our pathway, it's important to clarify that checking your lymph nodes is primarily a staging procedure to look for microscopic spread. It's not just an excuse for immediate removal. Let's move to and see how this builds directly off our earlier pathology ruler. A sentinel node biopsy is usually not recommended for uncomplicated, very thin melanomas under 0.8 millimeters. But as the tumor depth increases, or if adverse features like ulceration are present, it gets discussed. And once a melanoma is thicker than 1 millimeter, it's generally offered or discussed. The likelihood of needing this scales exactly with your specific tumor depth. So, what happens if that sentinel node does come back positive? I know, this is usually the scariest what if for patients. But the medical approach to this has undergone a massive, reassuring paradigm shift in modern care. In the past, the outdated approach was an automatic completion dissection, basically surgically removing all the remaining lymph nodes in that basin. Today, the modern standard has shifted heavily toward active observation. That means using regular clinical exams and high-quality nodal ultrasounds to monitor the area. A positive node does not mean you are automatically fast-tracked for aggressive, immediate surgery. Now, what's really interesting about this slide is the hard data behind this modern shift. A major study, MSLTII, found that 3-year melanoma-specific survival was identical at 86%, whether patients had all their nodes removed or just did active observation. But look at the lymphedema rates. Debilitating swelling plummeted from 24.1% with full dissection down to just 6.3% with observation. You get the same survival odds while dramatically protecting your quality of life. Section 4, Stage Match Therapy. This is where drug treatments enter the picture, and again, this is strictly based on the exact stage we've just methodically mapped out. For selected higher-risk stages, adjuvant therapies, treatments given after surgery, like pembrolizumab, can be considered to lower the risk of recurrence. But it's a very careful balance. These drugs aren't guarantees, and they carry potential, sometimes lasting, immune-related side effects. The decision requires weighing the absolute risk of recurrence against the burden and toxicity of the treatment itself. For advanced or node-positive disease, things get a bit more complex. It requires a coordinated, multidisciplinary program, not just an automatic drug choice off a shelf. Selected patients might actually receive a neoadjuvant strategy, which is immunotherapy before surgery. Or they might use checkpoint immunotherapy or targeted therapies if specific mutations like BRAF are present. It's a comprehensive strategy tailored exactly to your biology. Finally, regardless of your stage, you're going to have a standard follow-up plan. This routinely includes thorough skin examinations, lymph node checks, and reviewing any new symptoms. Routine imaging isn't recommended for early asymptomatic stages. However, lifelong skin surveillance is absolutely crucial because there's a very real risk of developing a second primary melanoma down the road. Section 5, Questions for your dermatologist. We've covered a lot of ground today, charting a path from that first pathology report all the way to advanced therapies. Let's conclude by transforming this knowledge into practical empowerment for your very next appointment. Here is your checklist. Feel free to pause this explainer or take a screenshot. Bring your actual pathology report directly to your treatment discussion and ask these exact questions. Ask if it's in situ or invasive. Ask for the specific Breslow thickness. Ask why a certain margin is recommended, if you should discuss a sentinel node biopsy based on your numbers, and what the true risks of any adjuvant therapy are for your body. By focusing on the data rather than the fear, you can take an active, informed role in your tailored care. So as you head into your next appointment, remember the question that started it all. Which specific pathology finding changes my plan? Keep asking that, and you will always know exactly where you stand.